أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم الحمد لله رب العالمين والصلاة والسلام على أشرف الأنبياء والمرسلين أبو القاسم محمد وعلى أهل بيته الطيبين الطاهرين. Assalamu alaikum wa rahmatullahi wa barakatuh, and welcome to this episode of the ICAIR podcast, where you are joining us in Toronto at the ICAIR Islamic Future Symposium in the JCC. And I'm joined this evening by one of the panelists on the Biomedical Ethics panel, Dr. Iqbal Jaffer. Dr. Iqbal, assalamu alaikum, and thank you for joining us.
Thank you very much for having me.
It's great to have you here. And I think to start off with, I want to learn a little bit about you. So talk to me about your backstory. Who is Dr. Iqbal Jaffer? Now, I understand that you moved from, you were born in Norway, you grew up in Kenya, and then you moved to Canada at age 7. Like, what was that like?
It's the interesting passport story. So I walk around with a Canadian passport that says born in Norway. It's got my photo in it. It confuses people. But what it does is it makes you an international citizen. And so you feel comfortable with lots of people. And so I find it very easy to talk to people and connect with people on different things. So I think it's interesting. I like it.
So you're a real global citizen.
Yeah, exactly.
Incredible.
Exactly.
So, but your profession now is you're a cardiac surgeon.
Correct.
But that wasn't always what you were going to be. You started out doing religious studies and psychology?
I did religious studies and psychology, and I used to think that I wanted to be a PhD in religious studies and study contemporary religious ethics. Actually, that was my honors thesis. But along the way, I was really inspired by a few things. I was working in medical research, and then my father had bypass surgery as well. And so that love grew again to go into medicine. I then applied to medical school a few times in Canada, didn't get in. And then I applied to a medical school in Australia, and I got in. Never been there, and I said, okay, I'm going. And because I always say that, my family's heritage is being attached to opportunity. Mm-hmm. When opportunity ran out in India, they went to East Africa. And when it ran out in Zanzibar, they went to the mainland. And when it ran out in Kenya, they came to Canada. So, what's the difference now? We get on a plane and we go somewhere else where there's opportunity. And so I went. And I got there, and I got on the plane, it was minus 15. And I got off the plane, and it was 35 with 80% humidity. I didn't stop sweating for 6 weeks.
Wow. So wait, so you've done Norway, Kenya, Canada, and Australia.
And then I married a British woman while I was in Australia.
So you're just hitting all the continents.
Yeah, we needed a South American nanny and a penguin. We got every continent covered.
I like that. But then, so how has that experience shaped your perception of healthcare system? Because obviously you've got the Canadian healthcare system, you've got the Australian healthcare system. Like, how many healthcare systems have you been exposed to?
At least 4. The British healthcare system as well, and then the American healthcare system also. I honestly think that the mix of public-private partnership done correctly is the right way. Canada is a completely socialist system. The UK is a completely socialist system. The American system is profiteering, and the Australian system has, some hybridization of that. I think that system works.
Right, and your specialty now is cardiac surgery. So you mentioned that your father had a cardiac bypass when you were growing up. Mm-hmm. Did that influence your choice of specialty?
So my grandfather had bypass surgery just before I was born, and then again when I was around 9 years old. Then my father had bypass surgery when I was in my 20s. And then, so I sort of had a social interest in cardiac surgery. But then when I was in medical school, one of my preceptors was a cardiac surgeon, and I kind of latched onto him, and he never got tired of my questions. He taught me all sorts of things, and so then the professional interest grew in that. And I still describe this to my trainees, to the medical students. The first time I saw a heart beating, and then not beating, and then beating again, I thought, this is the coolest thing ever. And I have seen this now thousands of times, and it still makes my heart happy every time. I say, wow, every time. I'm like, great, this is good. And it's just the feeling that you don't shake. And so I think that I started with a sort of a social, kind of a emotional interest in it, but now, the professional interest grew after that.
Amazing. And somehow you've sort of almost come full circle because, of course, now you're looking at biomedical ethics, right? So it's amazing to see how this has all kind of gotten woven together.
Yeah.
Now, your honors thesis was on medical ethics, wasn't it?
Yeah.
And it was a comparative study.
Comparative religious medical ethics between Orthodox Judaism and Shia Islam on the concepts of end-of-life care, autopsy, and organ donation.
Wow. And what were the key takeaways from that?
We come to similar decisions, but different ways of getting there.
Tell me more about that.
So the Orthodox Jews and us in the Shia school, we arrive at very similar decisions in terms of the sanctity of life and the preservation of life, but we also acknowledge the reality of death, and we acknowledge that life is suffering, and we acknowledge that there's another life afterwards. And so some of the pathways that we arrive at the decisions are different, but the ultimate rulings are about the same.
Very interesting. So it's almost like we have different routes that we take, but we arrive at very similar conclusions. And have you had any more experiences with like interreligious sort of biomedical ethics?
Yeah, I mean, in terms of dealing with Muslims of other schools, we've had some discussions with those, and then with Christians as well. And again, I think that in Christianity, depending on which brand of Christianity you are, there's a bit more fluidity and such. And many people don't know their own rules. I've had Catholic friends tell me that I'm more Catholic than they are, because
or more Catholic than the Pope, perhaps.
That's right. And so it is interesting, and I've always enjoyed that dialogue that exists.
And how would you say your interest in biomedical ethics relates to your day-to-day experiences as a surgeon?
Cardiac surgery and palliative care, and maybe a little bit of oncology, are really the only specialties in medicine that routinely talk about death. Cardiac surgery also offers the most amount of life-sustaining therapies. And so the interest is organic. I mean, understanding the technologies that I can offer and in what context we should offer them is, a day-to-day part of my life. And so I treat patients with expensive valve therapies that are in their 90s. And but I also refuse patients who are in their 70s for the same therapy because of certain conditions and whatnot. And so understanding religiously and ethically where these boundaries lie is just you come by it honestly, as it were.
Yeah. So it almost as a result of you just going through your day-to-day job as a surgeon, you're confronted with quite literally life and death decisions, and then you're almost forced to.
Exactly.
I mean, is it possible to be a physician or a surgeon without considering ethics, without sort of coming face to face with these decisions?
I mean, I guess, but it's just not a nice way to be.
Yeah.
Yeah. I think it's possible, but even then, if you look at even secular ethics, we have fiduciary agreements, responsibilities to our healthcare systems, which are vastly broken everywhere. We have ethical responsibilities towards the current patient, the next patient, in terms of resource utilization, in terms of, and resources not just being procedures and whatnot, beds, our time, our energy, our effort. And then also the concepts of quality and futility come up all the time. So I think that they're real, whether you frame them in a religious way or in a secular way.
Amazing. So, we've been here this afternoon having our panel on Islamic biomedical ethics, focusing on end-of-life care. And this is a topic that's become really controversial lately because of new legislation that's passed in Canada regarding medical assisted dying, and similar legislation is coming out in the UK and other countries. So it's a very timely discussion. Can you talk to me about what are the stakes when we come to end of life care? Like what are the discussions around end of life care? Like for someone who's never had to deal with this before.
Right. the biggest questions that come up for people at the end of their life are how much to do and for how long. And so, the availability of certain things is vast. And like I said, I have access to multiple treatments that can keep people alive, I wouldn't say indefinitely, but for a very long time beyond what might be reasonable in another context. And so the question isn't so much about what we can do, it's what we should do. Mm-hmm. And so the difficulties are always around how much and for whom and for how long.
So just to crystallize that, could you give an example case?
Sure. Let's talk about the hardest population to consider these questions in is the 50-year-old man, right? The 50-year-old man is sort of the start where men start to develop significant heart disease, but they have a lot of life ahead of them still. And so that person is the person we offer almost every intervention to. But even those people suffer from some irreversible things. And so then the questions are around, should we carry on with this? What quality of life are they going to have? They're never going to re-achieve the expected life course that they were going to have before this event occurred to them. And so in that vein, should we keep going with what we're doing? I can put people on heart-lung machines and keep them alive for weeks, mm-hmm. and I have done, mm-hmm. especially during COVID. I can keep people on ventilators alive for weeks, and I have done, especially during COVID. And those then questions become very tricky. It's not so difficult when it's an 85-year-old person who says, I've had a good innings, as it were, mm-hmm. And they say, well, I don't want any of this. Those are easy. But the 50-year-old man who's got a lot of life ahead and his children are young and his wife is dependent on him and this and that sort of thing, these are difficult.
And I feel like we should have maybe defined this earlier, but we're talking about biomedical ethics. What is biomedical ethics then?
Sure. Biomedical ethics is really the interplay of holistic decision-making that's either grounded in secular theory or secular thought, or religious theory and religious thought, and the interplay of complex medical decisions. So it is not the can we do this, it's the should we do this. Mm-hmm. That is really the definition of biomedical ethics.
Right. And coming back now to end-of-life conversations. So when you're dealing with questions in end-of-life care, there's obviously a patient there, and there's the patient's family, and there's you, the physician. What are the most difficult questions that come up in end-of-life care? Or the most difficult discussions to have?
Sure. We can look at it two ways. So let's assume that the patient can't speak for themselves. Mm-hmm. So the difficult questions that come up from we'll talk about the family and we'll talk about the healthcare providers. So from the family perspective is, how did we get here? Should we have done this? Should we stop? What would it look like if we stopped? Is there more that we can do? Those are sort of the difficult questions that come up, and sometimes they require a very frank answer. Sometimes there is no answer. From the healthcare perspective, it is this is no longer useful. Mm. This is futile. This is, maybe we shouldn't have done this. And how much longer are we going to persist with this? Mm-hmm. I think these are the difficult questions that come up.
And of course, sometimes you can say that a treatment's futile, but the patient or the patient's family don't necessarily want to hear that.
That is correct.
And how do you deal with those situations?
They're difficult, and I think that they require empathy. They require patience with a CE rather than with a TS, and they require repeated conversations. Mm-hmm. Some families, some patients are easier to get through to, as with all humans, and some are not. Mm. And for the most part, the ones that end up in the news are the ones that become really acrimonious. Most physicians do not need to get to this situation, and most most of these situations are handled very tactfully, day in, day out at multiple healthcare institutions all over the place, but some get acrimonious.
Right, and of course, I suppose it varies from one community to another, but I imagine faith plays a big role in these conversations. Depending on the faith or lack thereof of the patient and their family, that will affect how they're dealing with it.
And I think that it's a very important aspect of what we consider and how people have grounded their decision making. But one of the issues that we discussed both in the panel and that has come up in our real lives is that people have a general sense of what their faith demands of them, but they don't have the practical sense of what that actually means. And so they say, well, we have to sustain life. Well, I mean, do you? And in what context? And what is it that you actually need to do? And they don't have the answers to that. And I think that it's very difficult for people of good conscience to understand all of the nuance that we're trying to present to them. Understanding that, even me who works in a tertiary care cardiac surgical center, knows more about certain things than a person who works not in that place, who is a physician. And so to expect this of the general public who are trying to be ethically grounded in their faith is very difficult. And so I think we need some multiple gaps bridged.
Yes, I mean, and that's one of the goals that we've got behind the seminar, right? Bringing together religious experts, medical experts, and actually trying to talk about these difficult issues together.
Exactly.
And I think, there are no easy answers, right? And these are difficult conversations. And I think one thing that struck me is, for the patient or the patient's family, they're trying to understand all of this while facing a traumatic, a traumatic moment for themselves, for their loved ones.
Yes.
So that must add a whole other layer of emotion and complexity that you then have to navigate.
Well, what it does is emotion sometimes takes away rationality, and so then people become rooted in repetitive words. We can't, and we must, and trying to break them out of that to try and help them understand rationally becomes very difficult. And I think that that's just a function of being human rather than anything else. But emotions really make things difficult sometimes.
But of course, it's not just difficult for the patient or the patient's family. It can also be difficult for the medic or difficult for the physician. And something you were talking about today, which really, I think, really surprised me, because it's not something I'd thought. When we talk about biomedical ethics, I think we're always thinking about what we're doing to the patient or what we're doing for the patient. We're not always thinking about the impact that has on the person administering the care or the person in charge of the care. So you used a term today which was moral injury and the second victim phenomenon. Yeah. Can you just explain to us what that means?
Sure.
What is moral injury?
So moral injury is when you face a scenario in which you cannot provide the ethical care that you deem is correct because of a constraint. Now that is either a practical or an institutional constraint, or a religious constraint, as it were. And it's the inability to reconcile those that causes a phenomenon called moral injury. Accumulated moral injury can lead to multiple issues, including loss of self, depression, anxiety, changing your practice patterns, and that's what we call then the second victim. And so physicians, healthcare providers who face repeated moral injury become victims of their circumstances.
Without wanting to minimize what other physicians go through, I think Muslim physicians almost face a double risk of moral injury with the new legislation coming through, right? Because can you talk a little bit about that?
Yeah, I think that actually not just Muslim physicians, but all physicians of faith face multiple challenges when it comes to this. The Catholics and the Jews are pretty vocal about it, but they have their institutions that protect them. St. Mary's Hospital in wherever, can set a blanket policy that we do not offer MAID. we do not offer abortion because that is against Catholic teachings. Mount Sinai Hospital can also say the same thing. In the West, we don't have, Jaffer Islamic Medical Institution. And so we can't set these blanket policies. And so when people work in these places where we have policies dictated to us, the risk for moral injury is high.
And how do we navigate that?
Yeah, I think that discussion and clarity is really the first way. I think that as much as the general public doesn't understand what their faith demands of them, I don't know that physicians fully understand what their faith allows them to do. We talked in this session today about the practice of MAID, and we all very clearly understand that we are not going to be offering MAID, but is it haram upon you to refer someone for MAID? Is it haram upon you to do the first assessment, which you actually certify that somebody has an incurable illness or wants this? And we don't know. And so some clarity around those things would, I think, help minimize those things, minimize those possibilities for physicians to face moral injury.
So is this something you would say we don't talk about enough in our communities?
Certainly not. Certainly not. I think we only talk about death when it's an abstract concept. When it comes from the mimbar, we talk about Imam Hussein's death all the time, but we don't talk about our own. It's enough to say, kullu nafsin dha'iqatul maut, and then go, yeah, that's good. Everybody's going to face death. Death and taxes, they happen, But, let's talk about it practically, right? What decisions are you going to make when you are facing your own death? We talk about paying your Jamaat dues so that they'll bury you. Great. But how do you get to that burial? How do you get from that hospital stay to your burial? The time in between is one of the most stressful times for you, for your family, for everybody.
So it's almost as if this is something you need to prepare for.
Absolutely.
It gives a whole new spin to the Islamic sort of maxim to die before you die. It's almost sort of be conscious of that and prepare for it and be ready for it.
I mean, the number of people that, have even experienced a traumatic death in their family, and I mean traumatic in terms of emotionally traumatic, not, they didn't die in a car accident, but they died somebody in their family died a prolonged death, who faced many challenging questions around this person's death, who they themselves do not have advanced directives, who do not have conversations amongst their own family and loved ones, is enormous. You would think that it's in front of your face, and you would then think, well, I never want this to happen to the people that I leave behind, but yet it happens.
So you would say we almost need to institute a program in our communities to facilitate these conversations, to encourage people to have these conversations.
We have the Islamic will writing course. We have the Islamic will discussions. Let's have the Islamic Advanced Directives course, the Islamic Advanced Directives Islamic Direction course.
And just to clarify for those who maybe don't know what that is, an advanced directive means sort of you're making known your wishes in case of terminal illness or being incapacitated.
That's exactly.
So it's almost like a medical will.
That's exactly right. Yeah. It's a medical will. That's a great way to put it. And it is it can be holistic. It doesn't have to be specific, but it can be specific. Just as your Islamic will in terms of your assets and whatnot needs to be specific in certain ways, but can be nebulous in other ways, this can be the same.
Right. So this is really important. But I think one thing I want to just circle back to is sort of the weight that's on the surgeon or the physician's shoulders in making these life and death decisions, in guiding people through these processes, and having these difficult conversations. That must create a lot of not just psychological, but I think spiritual weight. And I'm just wondering, when facing these sort of tough conversations and in many cases these tough outcomes, what role does faith play in that for a healer, for a physician?
Yeah, it's a great question. For me, I'm not going to say that it never happens, but ala bi dhikrillahi tatma'innul qulub, right? So for me, I recite Quran, I recite Ziyarat Ashura. This helps me, and it makes me feel connected, and it as it were, lets me get up to fight another day. But yeah, these are traumatizing events, and I said that every surgeon carries a mortuary of patients that they acknowledge, a graveyard of patients that they acknowledge, their complications, whatnot. When we make these tough decisions, when we have these tough conversations, we keep those in our memory banks too. Like the adage is, have a short memory, but a really good logbook. And so forget about what's happened now, because you got to take care of the next patient, but just make sure that you reflect on your logbook once in a while.
It's almost as if you don't have time to process that, because
sometimes you don't.
There's, there are other people. There are other people who are in just as dire circumstance and who need your help. I mean, do we do enough, do you think, as communities to support our physicians and to provide systems of support for them? Because everything you just described there, it sounds quite, if you'll put me, that sounds quite lonely.
It can be. It can be. So the short answer is no, I don't think we do. And I think that, if I can be so bold, that from a community perspective, we think that perhaps because people have wealth, that they're protected from certain things. They're not. And I think that being able to deal with these things in a more holistic way would be a moral good for the community and for physicians as well.
Absolutely. So what would that look like in practice?
I don't know. I think that we focus so much on trying to reduce injurious events through clarity, but I don't think that I've actually reflected on how we put people back together, which is ironic because I'm a surgeon and that's all I do. But yeah, I don't know. I need to think about that more.
I think that maybe that's a discussion we can have, on another episode of this podcast. This has been a really profound and eye-opening conversation, and I really want to express my gratitude to you, Dr. Jaffer, for actually opening up and sharing these painful experiences with us, because I think if we don't have these conversations, then we can't start planning how to deal with these issues. And I think one thing that came out, I was just struck in the panel today just by how much doctors have to carry with them, whether it's people in geriatrics or pediatrics or just whatever profession, whatever branch of medicine they're in, they're never far removed from these realities. And in some branches of medicine, like if you're in palliative care, you're dealing this with every day. So before we go, I'd just like to ask you if there was one piece of advice or one thing that you wish that people could understand about healthcare, what would that be?
I see. You're ending on a good one. I think that people would benefit from taking charge of their own affairs in a meaningful way. And what I mean by that is people are very ready to deal with their assets, but they're not ready to deal with their issues of mortality and issues of leaving people the tough decisions. Make the tough decisions for yourself. Be ready to understand what options are ahead of you and use whatever resources are there for you to prepare yourself for those decisions that may come to you. God willing, they never do, but when they do, or if they do, then you don't burden other people that you love with those decisions.
I think that's an excellent piece of advice. Thank you so much, Dr. Jaffer. And I think one thing I'm taking away from this conversation is there's actually so much more that we need to talk about in terms of not just end-of-life care, but I think biomedical ethics as a whole. This is a whole field of discussion that we need to explore. And I think the panel we had today was amazing on so many levels. It was an eye-opener on so many levels. And we want to continue that, at ICAIR. So we're doing a research project into end-of-life care and the biomedical ethics of end-of-life care from an Islamic point of view. And I think our goal really now is to take these questions, to take these problems, and working with medics like yourself and Islamic scholars to develop solutions for our community, not just medical solutions, but spiritual solutions for our community that take on board some of these points. And I really hope that we're able to talk more about this in the ICAIR conference in June, which I hope you'll join us for.
I would love
Dr.
to.
Jaffer. I think we'd love to have you. And just thank you so much again for joining us.
It's my absolute pleasure. Thank you very much.
Thank you. And to all of our viewers and listeners, thank you for joining us. And if this episode resonated with you, share it with someone who you think needs to know this. Wassalamu alaikum wa rahmatullahi wa barakatuh.